Excellent. So welcome to this webinar on threat, trauma, and the vagus nerve, and sponsored by the Polyvagal Institute and electroCore. I'm Dr. Mark Tager, and I'm really honored to be the co-founder along with Dr. Peter Stotz of the Vagus Nerve Society. And we're a multidisciplinary global nonprofit, and our mission really is to present the latest research and clinical applications of the vagus nerve and vagus nerve stimulation. Now, my background's been in the realm of functional integrated medicine and ways that we can better communicate key concepts to practitioners. For today's session, the chat will be disabled, and please put all your questions in the Q&A. Now, just for ease of getting through the session today, I'm going to introduce all three of the speakers right now. And then we'll take your questions at the end of the session. So I'm pleased to introduce Dr. Stephen Porges. He's a psychologist and a neuroscientist. He's got many academic appointments. He's the distinguished university scientist at Indiana University. He's a founding director of the Traumatic Stress Research Consortium. He's a professor of psychiatry at the University of North Carolina and a professor emeritus at both Illinois and the University of Maryland. And he's the founder of the Polyvagal Institute. So this is really, he's been at the forefront of this research into the transformative power of feeling safe, which is kind of my favorite phrase. And he's going to start off by exploring the polyvagal theory and how it relates to vagus nerve stimulation. Then we'll move to Dr. Peter Stotz, who's got a long career in interventional pain medicine. He was a founder of the division of pain medicine at Johns Hopkins and the division chairman for nearly a decade. He's been president of many of the major organizations. He's past president of the American Society of Interventional Pain Physicians, NANS, the North American Neuromodulation Society, and other societies. He was the first chair of the American Society of Anesthesia's Committee on Interventional Pain. He's got over 500 peer-reviewed publications, and he's going to hone in on non-invasive ways to stimulate the vagus nerve. Dr. Doug Bremner is a professor of psychiatry and radiology and director of the Emory Clinical Neuroscience Research Unit at Emory University School of Medicine. And he's got a great consumer book with a wonderful title that says, you can't just snap out of it, the real path to recovery from psychological trauma. And Dr. Bremner he'll be speaking of some of his research looking at vagus nerve stimulation for PTSD, and also mention a little bit about its emerging use in opioid use disorder. But before we get started, I'd like to just turn to Dr. Stotz for just a bit more color on our two really exceptional presenters. Peter?
Well, thanks so much, Mark. I'm actually really thrilled with our talk tonight. It's really an opportunity for us to take two areas of medicine that have been somewhat disparate and separated and pull them together and give an overview of a unified approach towards how, for me, Polyvagal Institute and polyvagal theory can be applied to modern medicine today more broadly, and then to provide some cutting-edge research that Dr. Bremner has been doing on external vagus nerve stimulation with the theory and the applications combined and intertwined together. This really should be a wonderful webinar, and I'm very grateful to my esteemed colleagues, Dr. Porges and Dr. Bremner, for agreeing to join us for this 1-hour webinar. Thank you, gentlemen, and thank you to everybody who's joined in to this wonderful meeting tonight. Dr. Porges, I'm turning it to you.
Okay, well, thank you, Peter. So I'm actually going to talk about vagal nerve stimulation, obviously, and I'm going to kind of phrase it through the lens of polyvagal theory. But first, I'm going to try to do an overview of polyvagal theory. Most of us are familiar with the vagus as a nerve. It's the primary nerve of the parasympathetic nervous system, as we can see in the right-hand side of this picture. And then we've often viewed it as the autonomic nervous system as a paired antagonism system in which the sympathetic is really the energizer or the accelerator, and the vagus is the brake. And this model has been literally prevalent in all our training. However, we're going to kind of view it in a new way. And you'll see the slide again because I borrowed it from Doug's deck. And the issue is what polyvagal theory says, it really updates our view of the vagus. And if you look at the vagus nerve, this large nerve coming out of the brainstem, cranial nerve 10, you start seeing that there are really two different branches, a branch that goes above the diaphragm, primarily to the heart and the lungs, and a branch that goes below the diaphragm, primarily to the gut. And they actually emerge from different areas of the brainstem. And that's why they have the name ventral, because one being more the front of the brainstem and being myelinated fibers, and the other one being dorsal in the back of the brainstem. And this requires us to reconceptualize what we're thinking about in terms of the vagus. And when we cast this within a model of evolution, we start seeing this ventral migration in which cardioinhibitory cells move from the dorsal vagus to the ventral vagus. They move from the back of the brainstem to the front of the brainstem. And we can see that the dorsal vagus, which was the primary vagal pathway until till the emergence of mammals as they became distinct from ancient extinct reptiles. And what you're seeing is that dorsal vagus came in about 400 million years ago, or 450, and about 400 the spinal sympathetic nervous system comes in. And by 220 million years ago, when the initial mammals emerged, there were two important features. One, they could suckle, which meant they had a ventral vagus that was functioning. And two, they had detached middle ear bones, which meant that they could hear and listen to frequencies that reptiles couldn't listen to. And that became part of the defining features of mammals. Now, this gives you an idea. We've been talking about the vagus, and everyone talks about the vagus, but the vagus is really a conduit with many fibers coming through it. And we can see fibers from an area called the nucleus ambiguus, which in polyvagal theory is the ventral vagus. You have spinal sympathetic fibers coming into the vagus, nucleus solitarius, and this is the sensory vagus. And this actually is basically about 80% of the vagal fibers are basically originate or terminate in the nucleus of the solitary tract, and then the dorsal motor nucleus. And a way of kind of conceptualizing this is really to visualize this as literally this ventral migration where the cardioinhibitory cells are actually moving towards the ventral part of the brainstem. And when they do that, something extraordinarily interesting happens. They start to become integrated with the cranial nerves that have pathways that regulate the striated muscles of the face and head. So that ventral journey enables the striated muscles of the face and head to be connected in the brainstem with the ventral vagus. And so it's not all of the fibers from trigeminal, facial, glossopharyngeal, vagus, and accessory, but a special group of them that are called special visceral efferents. And those are the ones that actually evolved off of the pharyngeal arches or ancient gill arches. And they literally merge together with that ventral vagal cardioinhibitory pathways that enables now mammals to literally broadcast their physiological state in their facial expressivity and in the intonation of their voices. Laryngeal and pharyngeal nerves actually are vagal nerves as well. So our social behavior is really a product of the history of mammals broadcasting their physiological state to others of their species to signal and trigger them that they were safe enough to come close to. So we can kind of summarize the theory that it was derived from the phylogenetic and developmental investigations of the autonomic nervous system, including embryology. And this identifies this phylogenetically ordered response hierarchy that regulate behavioral and physiological adaptation to safe, dangerous, and life-threatening environments, meaning that our newest circuits support safety and social interaction, then danger, which is our fight-flight sympathetic nervous system, and life-threatening environments, which causes shutdown, happens now also to be a vagal reaction in general. So what we start learning from polyvagal theory is that the vagus is also this promoter of connection and sociality, supporting homeostatic function, but under severe life threat, it can actually shut us down and disrupt our physiology. And this is seen, of course, in subdiaphragmatic gut problems, which are frequent comorbidities with trauma histories. And this theory explains how signals of threat disrupt homeostatic functions, leading to illness and disease. The theory also basically explains that acute and transitory effects are very adaptive, but when our nervous system gets locked into a state of threat, that creates functional disorders before end organs are damaged. Explains how signals of safety act as neuromodulators, basically like a vagal nerve stimulator, to promote spontaneous social engagement behaviors and optimizes homeostatic functions such as health, growth, and restoration. And this, again, is that picture of those 5 cranial nerves that are involved in the social engagement system. But now we're posing a different question. We're posing the question that since they are talking to the vagus, since there are both direct and primarily indirect connections between the source nuclei that regulate these cranial nerves and the vagus, are they portals to stimulate the vagus? So in a sense, if we're using our middle ear muscles, which have afferents for the social engagement system through cranial nerves 5 and 7, will that impact on our autonomic nervous system through our ventral vagus? And can we create an acoustic vagal nerve stimulator? And that's exactly what I've done. I've actually tried to treat acoustic stimulation as a non-invasive vagal nerve stimulator. And we can basically, it's asking this question, can we enhance social engagement function through listening using an acoustic vagal nerve stimulator that calms the autonomic nervous system and can effectively stimulate the system? And again, so the question really is, and here's the other part, the eardrum itself has afferents for cranial nerves 5, 7, 9, and 10. So a movement of the eardrum with acoustic waves is actually potentially stimulating the vagus. Now, an interesting study we did was looking at the effect of maternal vocalizations on infant distress. So the paradigm was that it's something called the still face paradigm, but basically the infant's placed in a state of stress. The mother then re-engages the infant with talking to the infant, and what we calibrated and quantified was how prosodic, how much intonation was in the mother's voice. And if the mother's voice had a lot of intonation, the baby's distress behaviors rapidly and profoundly were reduced. And we measured the baby's heart rate. And likewise, if the mother's voice was prosodic, the heart rate decreased, calmed down. But if the mother was still talking to the infant, but her voice was less prosodic, it had little effect. So this became literally the neurophysiological basis of it, what I call the listening project protocol, which was my laboratory attempt to use acoustic stimulation to calm. But it was structured as a neural exercise to trigger that social engagement system. But as a neural exercise, it was building resilience. It was not about a prosthesis of stimulating and helping or calm while the stimulation was on. It was building capacity in the system. And in our research, our first trials, we were working with autistic children, and it reduced auditory hypersensitivity and improved emotional control. And the computer altering of the music, which was the intervention, which was to amplify the intonation changes. And the intervention was 5 one-hour sessions with this computer altered music. It was profoundly effective and differentially effective from the unfiltered music, the unmodulated, extra modulated. However, just listening to music enhanced spontaneous speech and listening in the children, but it had little effect on emotional control and hearing sensitivity. And then we looked at the ability of the children, these are autistic adolescents in this study, to process auditory signals. So there's often this issue of what's called central auditory processing deficits. And the autistic children, on filtered words, which is very muffled, did extraordinarily poorly relative to age controls. Similarly, with competing words, where they get one word in the left ear and another word in the right ear. But when they went through the intervention, after the 5-hour intervention, their auditory processing was normalized. And we also measured vagal tone by looking at the amplitude of respiratory signs, arrhythmia in the heart rate, and got noticeable significant changes between pre and post treatment. This intervention was later commercialized by a company that was called Integrated Listening Systems. It was then purchased by Unite, and it was framed as the safe and sound protocol. And what this is a study that is in press, or it's actually published already, on looking at the sensory changes in autistic individuals, auditory hypersensitivity. This is their baseline, and 1 week after, 1 month after, its hypersensitivity is reduced. Difficulty in pulling out human voice normalized in 1 week and maintained it. Visual hypersensitivity also reduced and remained that way. Tactile hypersensitivity reduced. Digestive problems reduced, and selective eating. The offset was about a month later, and they were now more curious about foods. But in much research, it's very difficult to measure physiology. So we developed a body perception questionnaire that provides a subjective index of autonomic reactivity, including super diaphragmatic, the ventral vagus, and subdiaphragmatic, the dorsal vagus. And this was then used in research. And this is a study looking at functional neurological disorders in a 10-year-old child. It's a case study in which the child was basically hospitalized in residential care. And because the child was in chronic pain and couldn't function, and they tried everything, nothing worked. And then they tried the safe and sound protocol, and things like on the DAS score, the child was normalized in depression, anxiety, and stress. And in terms of our body awareness questionnaires, our autonomic reactivity, the child moved from very high clinical ranges to normal. So the autonomic state changed and the clinical symptoms. Then we did a study with people who had anxiety disorders, depression, and speech problems. And they also reduced, their anxiety was significantly reduced. These are adults, and it's 5 1-hour sessions. Their depression was noticeably reduced. And likewise, from the body perception questionnaire, their autonomic reactivity was also normalized. Vagal nerve stimulation through the lens of the polyvagal theory emphasizes the link between functions of this ventral vagus complex and mental and physical health that can be reduced through vagal nerve stimulation. It shifts the emphasis of vagal nerve stimulation from the entire nerve to select afferent pathways that communicate with brainstem areas regulating both somatomotor and visceromotor efferent pathways originating in the ventral vagal complex. It expands the portal of vagal nerve stimulation to the entire social engagement system. And there are products out there like the Monarch that stimulates a branch of the trigeminal that comes to the forehead that has effects similar to a vagal nerve stimulator. And this is quite consistent with polyvagal theory, saying that the afferents from the trigeminal, the afferents from the facial, these are also affecting nucleus ambiguous. And this contrasts applications of vagal nerve stimulation from basically a prosthesis where the stimulation is used to reduce symptoms versus a neural exercise to build resilience. There's an update of the polyvagal theory. It's in a journal called Comprehensive Psychoneuroendocrinology. The vagal paradox. Anyway, okay, there. The vagal paradox. And that's available to you. And basically, I'm done. Well, thank you.
Well, thank you, Steve. You're never done. Can we go back a couple of slides? We went a little fast. Again, I'm Peter Stutz. I am by background an anesthesiologist and interventional pain physician. And when I got started in this area, I didn't know much about the vagus nerve. I knew don't hit it when I'm placing a central line. And Steve has really given a wonderful framework for understanding the impact of threat, stress, and the vagus. And he really concentrated for us today at the brainstem functions. And he talked about the nucleus ambiguous and the nucleus tractus solitarius. What I want to do is spend a couple minutes, and I feel like the filler between two cookies here because we've got two great speakers and I'm going to go quickly, but I wanted to talk a little bit about, sorry, I'm losing my thing here. A little bit more detail about the vagus and how we can actually access this, whether we call it a prosthesis or whether we're using it as a biohack, we can talk about it in our discussion section. But the vagus nerve, as mentioned, is the 10th cranial nerve. It is probably not known, but it is the most widely distributed nerve in the body. It goes through all of our organ systems, as you see here. And importantly, it has both sensory and motor, both afferent and efferent components to the nerve. And this is going to turn out to be important today, but it's also going to turn out to be important in some of the upcoming lectures that we give over time. The vagus nerve controls and also gives information to the brain on the state of the organ and the body's systems. It can cause bronchodilation. I became interested in this very early on, trying to come up with a strategy to bronchodilate somebody with an asthma attack or a patient with anaphylaxis. And that's good for another day, I think. We'll talk about that later. But it also has been shown to be important in gluconeogenesis, gastrointestinal motility. And I think thematically, you'll find that this is going to be important in systemic inflammation and inflammation that is associated with diseases, broadly speaking. Today, we're going to talk a little bit more acutely about threat, PTSD, and inflammation as well. Now, vagus nerve stimulation has been around literally, as Steve was mentioning, for thousands of years. Ancient Tibetans have talked about the use of vagus nerve stimulation with meditation. They may not have called it that. There's acupuncture approaches that have been identified literally from thousands of years ago as well, identifying that there is a strategy to access to try to modulate disease. But I think the modern history of vagus nerve stimulation really starts in 1997. Cyberonics, now Livanova, were founders of this area, and they came up with a strategy for treating epilepsy. And they got the first FDA clearance for a medical device, an implant, for treating epilepsy in 1997. It's still widely used for refractory epilepsy out there. The same company also got a clearance from the FDA for refractory depression. And we'll start to see why these areas are somewhat linked. And then I started working on this with the group at electroCore in 2004 on diseases such as airway reactivity, headache disorders. We have expanded very broadly into a number of neurologic inflammatory disorders. There are 6 different FDA clearances for primary headache disorders, such as acute treatment of migraine and prevention of migraine, acute treatment of cluster and prevention of cluster. But along the way, we've seen that there's a lot of other side benefits that occur with vagus nerve stimulation. And we'll be covering those in subsequent webinars. Now, taking the vagus nerve from where Dr. Porges left off in the brainstem, it drops down through the neck and it goes down through the carotid sheath. So if you can all reach up to your neck and feel your carotid pulse, that little bump, bump, bump that you feel in your neck, that's your carotid artery. The vagus nerve runs down the carotid artery in what's called the carotid sheath there, and then it branches off into 4 different branches, which is, again, providing information to the organ systems, and then given the organism's state of the art, or state of their function, they're providing information back to the brain. The vagus nerve, as I mentioned, covers a variety of different disorders. We see stomach, we see gastrointestinal, we see small intestine, we see spleen here. All of these are incredibly important and are already highlighted in a different in the earlier presentation. Now, generally speaking, I think of vagus nerve stimulation as 4 different approaches, or the natural approaches, which I think are really important. And when I'm, asked about, well, what else can I do? There are obviously things that we can do with cold immersion, meditation, deep breathing. And Dr. Porges pioneered the concept of safe sound protocol, which is also activating the vagus nerve. There are implanted vagus nerve stimulators, and we talked about the Cyberonics approach, and there are other companies that are studying this right now, looking at treatment of inflammatory disorders such as rheumatoid arthritis and other inflammatory states. There are devices that have been created. Medtronic had one of these where it stimulated the fundus of the stomach for obesity. There are auricular nerve stimulators, and there are advantages and disadvantages of that approach, but they have about a 960 or 980 vagal fibers that are all all afferent fibers that land in the trigeminal nucleus. And then there's non-invasive cervical vagus nerve stimulation, which has the advantage of having both afferent and efferent components. They project up into the nucleus tractus solitarius and the nucleus ambiguus, but they also have efferent components that actually control organ systems and organ function, such as systemic inflammation. And that's pioneering work done by Kevin Tracy 20 plus years ago today, looking at the efferent import of vagus nerve stimulation. And it's important to note that not all cervical vagus nerve stimulations are created equal. We did a lot of work early on to try to figure out what frequency is required to stimulate the vagus nerve for maximal effect. And we alighted on this 5,000 kilohertz or 5 kilohertz or 5,000 hertz sine wave that is pulsed. It's got, as you can see here, it's got about 5 waves that's pulsed at 1 millisecond for 1 millisecond, about 25 hertz. And then we repeat this every 2 minutes. And this framework has been extraordinarily deeply studied and broadly studied to be an effective strategy for stimulating the vagus nerve. And part of the advantage here is that the vagus is relatively uniformly about 1.3 to 1.5 centimeters deep to the skin. And that gives us a target, an amplitude, and a frequency that we can use to activate the vagus nerve. And we also have a pretty reliable position. And as I mentioned earlier, we can feel the vagus nerve. You can actually not feel the nerve, but you can feel the carotid artery, and you know that the vagus nerve is running right there. So it's a pretty reliable target for patients to stimulate themselves. There have been a number of studies. Early on, people said this is impossible. You can't stimulate the vagus nerve. I just pick out one modeling paper that was published about 5 years ago now, showing that we could stimulate the vagus nerve pretty reliably using these frequencies. And then there are 7 or 8 other studies that have been done looking at EEG patterns, functional MRI studies, cytokine response, and I could go down the list here, but this has been reliably studied over and over to be shown to activate the vagus nerve. And then I'm going to conclude with this slide. One of the questions that I'm frequently asked is, as you know, Dr. Porges' slide talked a little bit about bronchoconstriction and bradycardia. That's largely mediated through the C fibers. And using this type of approach, when one tries to stimulate the vagus nerve, if you wanted to activate these C fibers, which are the myelinated fibers, you would have to have an amplitude of around 240 volts per meter, whereas we are stimulating maximally around 24 volts. And so we are well in a safe zone away from stimulating the C fibers. So it is a very nice targeted approach for activating the vagus. With that, I'm going to turn it over to my good friend, Doug Bremner, who's probably done more work in this area around post-traumatic stress disorder than anybody alive. So Doug, I'm going to turn it over to you.
Okay, thanks a lot, Peter. I'm going to talk a little bit about application of vagal nerve stimulation to stress, specifically PTSD and addictions. So post-traumatic stress disorder follows exposure to life-threatening event or with the and it also involves the neural circuitry involving the amygdala, the hippocampus, and the prefrontal cortex. One of the key points that I'd like to make tonight would be that the vagal nerve stimulation, as Dr. Porges pointed out, it's like a brake to the sympathetic nervous system. So the sympathetic nervous system is the fight or flight response, and the parasympathetic system acts as the opposite of that, and that's mediated through the vagus. So both PTSD and addiction share in common the fact that they're associated with activation of the fight or flight response. The with opioid use disorder, for instance, you get a withdrawal from opioids, and opioids typically inhibit the fight or flight response, the catecholaminergic noradrenergic system in the brain that helps us fight back or run away if we're attacked or under threat. And with chronic opioid use, you get an inhibition of that system. So when you go through withdrawal, there's this rebound effect. And so they look a lot like people with PTSD. So we can look at PTSD symptoms by activating them through either recording traumatic memories that that people experience in their childhood and then playing them back, or we can do neutral mental stress tasks, such as asking people to give a public speech or to do mental arithmetic with negative feedback. And we use those techniques as a way to activate symptoms of PTSD in this case, and look at some of the reactions. And what we see is we get activation of the sympathetic nervous system and of the inflammatory system. And we can look at use both brain imaging and use something we call wearable sensing devices and put it in an intravenous catheter and measure blood samples and look at activation of the inflammatory system. So this just shows the vagus nerve system, as you saw before with Dr. Porges. It's located in the brainstem, but then there's fibers that go throughout the body, both to the heart and the lungs, and all these fibers are acting as a brake on the fight or flight response that occurs with activation of the sympathetic nervous system. So normally with the fight or flight response, you get an activation of heart rate and blood pressure, increase in respiration, and those are all things that help us fight back or to run away if we're under threat. And the vagus nerve is acting as in the opposite way, as a brake on that system. So the vagus nerve was originally approved, as said in the previous presentations, for both epilepsy and for treatment of refractory depression. And those devices were implantable, and they showed a 68% clinical response rate. So they were effective for the treatment of refractory depression. But one of the problems with these devices is that they were never approved by Medicare. And so people that had surgical implantation of these devices did not have their psychiatric follow-up paid for. So there was some high cost in terms of the initial implantation that wasn't covered by insurance, as well as the follow through after the devices were implanted and the continued care that was needed, and the cost of psychiatric follow-up. So we wrote an editorial several years ago called Back to the Future. It was an editorial in conjunction with this meta-analysis that was done on the original implantable devices. And at the time, we were starting to do research in PTSD with the non-invasive device. And so as a psychiatrist, I saw this as a promising new approach that, because it didn't require surgical implantation, it'd have a more likely to be able to be widely disseminated in psychiatry. And so, I'm interested in the physiology of the vagus and interested in brain biology in general, but for things that can't be widely implemented in psychiatry, I have a less interest for. And so we thought that this was had some promise, and we did some longitudinal studies showing about a 31% improvement over the sham control. And yet, based on that, the FDA granted breakthrough device designation in 2022. So as I said before, you can stimulate both through the neck, which is the cervical branch, and as well in the ear. This breakthrough device designation was for the cervical device that you stimulated on the neck. So when we stimulate the vagus, this shows you the cervical device stimulator there. It stimulates on the neck, and there's both fibers that go to the periphery and the heart and lungs and liver, et cetera. But there's also branches that go back up through the brain through this nucleus tractus solitarius. And it activates neurotransmitters that are involved in both PTSD and depression, including acetylcholine, norepinephrine, and serotonin. And then these go throughout brain areas that are involved in mood and psychiatric disorders, including the cingulate, amygdala, and hippocampus. And then from there, we think that there's output that goes to the periphery that can influence things like peripheral sympathetic activation and inflammatory function. So the amygdala plays a key role in fear, and the hippocampus is involved in memory, and it's sensitive to stress. So we can stimulate here at the neck, and then we have these sensing devices that electrocardiogram measures heart rate, and then this is seismocardiography, which just measures the movement of the chest wall, and it can give us pictures of cardiac function. We can put on this purple thing as a band that measures respiration, and then we can measure the peripheral vasoconstriction with something called photoplasmography, and peripheral sympathetic function of sweat glands. So the EKG gives us that when the heart depolarizes, that's the R wave. So the distance between the R waves gives us heart rate. And then pre-ejection period is from the time when the left ventricle depolarizes to when the aortic valve opens. And as the cardiac sympathetic system increases, that period shortens. So we can use pre-ejection period as a measure of cardiac sympathetic function tone, and we can look at the effects of VNS on that. PPG amplitude is just the diameter of the peripheral blood vessels. And as the sympathetic nervous system activates, we get vasoconstriction. So that's another outcome measure we can look at with the effects of VNS. Next slide. And so what we found is this is anger, which is a behavior that's associated with listening to personalized traumatic scripts. And you see there's a blocking of anger there in the PTSD patients given active VNS. That's the orange symbols compared to the sham, which is the blue. Over on the right are traumatized non-PTSD people who don't really have an anger reaction at all. And we also showed that active VNS, it decreases respiratory rate, which is over here. That green is the reduction in respiratory rate. It causes a increase in PPG amplitude, which shows the vasodilation, and that's an anti-sympathetic effect in the active group, not seen in the sham group. Next, this is after a public speaking task, which is stressful. Next slide. And we see that both for respiratory rate. This is with after a mental arithmetic task in all subjects, with traumatized subjects, and also in both PTSD and non-PTSD, an increase in PPG amplitude, which shows a blocking of sympathetic function, and then a decrease in respiratory rate over here. This is before, and these are after the stimulations. We also get reductions in heart rate, and this shows again PPG amplitude increasing, and pulse arrival time, which is another marker of sympathetic function. And we see that both in the that's with the active PTSD compared to, but not seen in the sham. And also changes in pre-ejection period. There's an increased pre-ejection period showing a blocking of sympathetic function. And these are just measures of heart rate variability. So we get an enhancement of heart rate variability, which is a marker of improved, basically, sympathetic tone. We have these markers of stress. This is interleukin-6, which is an inflammatory marker, and over here on the right, and then this is a pituitary adenylate cyclase activating peptide. And over this 3-day protocol where they get mental trauma script stress on day 1 and then mental stress on day 2 and 3, you see that there's a gradual increase in this PACAB, which is a neuropeptide located in the amygdala that is a kind of a fear neuropeptide, which is blocked by the active VNS. And then this is on the day right after they listen to this trauma script. The PTSD patients, they have the sham in blue has a big increase in IL-6, about a 3-fold increase that's blocked in the PTSD patients. And over here on the right, you see non-PTSD. These are traumatized non-PTSD. They don't really have much of a reaction to these trauma scripts. So to reiterate, listening to trauma scripts increases anger, increases fear neuropeptides, activates the sympathetic system and the inflammatory system, and that's all blocked by active VNS. And this is interferon gamma. It's another inflammatory marker that is increased with the sham and after a trauma script and blocked by active VNS. And ghrelin is a neuropeptide that we found is reduced with with VNS after 240 minutes after exposure to the trauma script. And then this is just over ghrelin. This is overall with the mental stress like public speaking. And ghrelin is both involved in fear reactions, and it also regulates appetite. So that might be kind of an interesting connection between, stress-induced eating and possible interventions for that. And when we looked at this is the reduction, there's a greater reduction with active VNS and PTSD symptoms in red here, and compared to the sham control. So you get some effect with sham, but overall there's a 35% greater reduction measured with the CAPS in this case, which is the clinician administered PTSD scale. And then over here, this is the PTSD checklist. The hyperarousal, you see, especially hyperarousal is affected by the active VNS, and these are lines connecting individual patients before and after treatment. And then these are the means over here. So there's a greater reduction with active compared to sham in PTSD symptoms after 3 months of twice daily simulation. And we also found an increase in memory. So this is in the active VNS group. When we stimulate while people are listening to a paragraph and during the consolidation phase when they're trying to remember, and then ask them to remember after a 20-minute delay, with continued treatment, this is like at day 7, 34, 90, 64, they're getting twice daily self-stimulation treatments, and then they're stimulating themselves when they're listening to this paragraph. You get a 95% improvement in memory recall. So this is how much they remember. And then the sham group, we don't really see that improvement at all. Down here on the bottom, this is a working memory task, also some improvement there. And we showed that the insula, which is a brain area involved in stress, activates more with the sham while listening to the stressful scripts than the active VNS. So we get VNS blocking these stress brain areas, but enhancing function in the anterior cingulate, which is a brain area modulating emotion that extinguishes fear reactions in the amygdala. And just show you more activation here in anterior cingulate areas with the VNS compared to sham. And this is positron emission tomography, radioactive water, people being injected with radioactive water, which measures brain function while they're listening to trauma scripts as they're getting either VNS or sham. And we also showed that as there's an improvement in respiratory homogeneity, meaning that their breathing rate is more ordered and less disordered, you get a reduction in amygdala activation in the brain. So what we found is that disordered breathing is associated with anxiety, and it kind of makes clinical sense that PTSD patients have more of a disorder of respiration. And next slide. And we actually get an improvement in the homogeneity of this is expiration, so that the regularity of expiration is improved with VNS, and that's associated with the reduction in amygdala activity in the brain. This is in people with opioid heroin addiction undergoing withdrawal. So we bring them in, they stop using heroin the night before, and then we give them either VNS or an active sham. And so this is the visual analog scale of craving. You got a 20% reduction in drug craving with VNS, not seen in the sham group. And we also get a reduction in heart rate. So that's an objective measure of withdrawal. So normally heart rate goes up with withdrawal, and we're actually reducing it with the active VNS, not seen with the sham. So to summarize, we get a reduction in behaviors like anger with the traumatic scripts. We block inflammation and sympathetic responses to stress. There's an enhancement of memory and cognition. And we think that this has applications to PTSD and depression, and also other disorders such as long COVID that I didn't go into detail about today. And that's all, and thank you for your attention.
Great. Thank you very much to all the presenters. I really appreciate it. I think what we're going to do now is shift and take some of the many questions that we've received. We're not going to be able to get to all of them. We'll try to get to many of them. I guess, I want to address the first one for just a moment, which was the question about Botox and muscle inhibitors. Now, I live in Southern California, and I don't think I've seen a wrinkle in a forehead in quite a while. So to my understanding, and I'm going to toss this over to Steve and all of you gentlemen, that when you put in a neurotoxin, essentially what you're doing is preventing the presynaptic release of acetylcholine for a period of time, affecting the muscles. My understanding is that that stays pretty localized. However, now Steve, as we're talking about, these feedback loops of
Yeah.
facial expression and the freezing of facial expression. I mean, there's got to be some feedback and effect there. So perhaps you could address that.
Well, the two parts to your question. The first part is, yes, when the muscle moves, there's afferent feedback that's going into that area of the ventral vagus. So that's a given. But the other part is it's also a signal to other. So when the face is not responding, it's actually interpreted by others, like the babies, as still being a threat. So, or like the voice not having any intonation, a flat face. Now, how many people online will have sat across from a significant other and said, "Why are you looking at me that way? I didn't say anything." In a sense, their faces are flat and they're going to react to them as if they are basically an aggressive response. So when we anticipate in others let's say a facial nod, a smile, especially in the upper part of the face, the orbicularis oculi, and one of the favorite places for Botox, of course, of the crinkles of the side of the eye, and that happens to be a true characteristic of exuberance. So when people are exuberant, that's going to be a crinkle. And our bodies respond to that. It's part of our history, our evolutionary history. And when that's blocked, the reaction. So I'm saying there are two parts. It's the numbing of the feedback from that area, which is to the individual, but that individual is broadcasting now a signal to another that they may not have the intention of sending.
So one of the worst experiences I ever had was giving a presentation at the tail end of COVID to a group of aesthetic professionals, all of whom were wearing masks and all of whom had Botox foreheads. And there was absolutely no feedback.
Okay, your
no
point is good, but let's deconstruct that, because people would constantly ask me that about during COVID about the mask. But the interesting part is most of the signals we use for social interaction happen to be in the upper part of the face.
Sure. Excellent. Peter, let me toss a question over to you, and then I'll let you kind of steer the rest of the session. But there were a number of questions related to long COVID, and I know that you've done a good bit of work there. So perhaps you could sort of speak to some of the changes that take place in long COVID.
Sure. Well, let's step back a little bit first and talk about acute COVID. When COVID hit, I was particularly concerned for two reasons. As you recall, in New York State and Italy and this is a very international group on our call right now. There were two things that were happening that were pretty profound. One is we were running out of ventilators because people weren't able to ventilate. And the other thing that was happening is people were dying of what's called the cytokine storm. Now, Doug alluded to it a little bit, and I alluded it to a little bit, but the efferent pathway of the vagus nerve controls the inflammatory response, which is the cytokine reaction that can occur with an illness. And we actually did some studies, one here in the United States run by Boyle Chang, and one in Spain, in Valencia, Spain, run by Carlos Tonero. And both of them showed some similar things, some idiosyncrasies. The study in Spain was over 100 patients, and we were able to show a decrease in inflammatory cytokine C-reactive protein in a group that was treated with vagus nerve stimulator, as opposed to patients who were treated were just by the standard of care. Now, these were incredibly difficult studies, but it did start to show that the inflammatory response is really important. And then Boyle Chang's group also showed a similar thing with here in the United States. Now, this moved forward to a problem with long COVID. And I sat on a committee of long COVID people. There's a group called Survivor Corps for quite some time. And one of the theories that's occurring with long COVID is it's not just one problem. There's several problems, but one problem is a neurologic injury to the vagus nerve. That is one of the main hypotheses that are out there. And Ravi Ganesh at Mayo Clinic now is completing his study on an open label trial of VNS, cervical VNS in long COVID. And he tells me the results, preliminary results, are really quite promising. Then there are other studies using an auricular vagus nerve stimulator in long COVID as well that have also shown very promising results. And then finally, I should say there's a whole field of stellate ganglion blocks, doing injections onto the sympathetic nervous system to block the sympathetic nervous system. And they're finding positive results in some of the patients with long COVID. So there's a lot of reasons to believe this is an effective therapy. This is not an FDA-approved approach right now. These are areas of active research. And I should really qualify a lot of that things that we're talking about is active research here and not intended to be medical recommendations by Dr. Porges, Dr. Bremner, yourself, or myself. We're really just talking about the scientific basis of everything that we're seeing here today. Doug, did you want to add something to that on the long COVID topic?
No, that sounds great.
Okay, good. So, you know, one thought that I was thinking about, Doug, with your work on ghrelin. Now, ghrelin, you talked about it as a stress response, but it's also important in appetite and appetite suppression. What do you think about vagus nerve stimulation for appetite suppression?
I mean, it's something that we hadn't thought about before, but you know, there is this question of, you know, why is it that some people will eat more when they're under stress, or why is there a relationship between stress and you know, some eating disorders? So, and it's kind of interesting how some of these neuropeptides that are function in the gut, you know, we can use ghrelin as an example, but they also occur in the brain. You know, vasoactive intestinal peptide, VIP, in the brain causes anxiety, and it also has an effect on digestive processes. So something to, you know, maybe someone should look at that in the future as a you know, exploratory study, looking at it as a treatment for overeating.
Steve, what do you think?
Well, I have a different approach to this because I focus on ingestion, which is part of that social engagement system. And I also have a very deep developmental history of working with babies. And what you start learning is that early in life, ingestive behaviors are quite calming. And then social behaviors become more, let's say, potent. So that the food is not, I think the afferent feedback from ingestion stimulates vagal activity and is calming, but it loses its effectiveness developmentally and social behavior becomes more potent. So what you're getting is people attempting to calm their physiology through ingestion, and it's not very effective.
We've had a number of questions come by, Pierre. I just want to
please
interject here for a second. On are there side effects for some of the vagus nerve stimulation? What do you see? So specifically, a question was asked of Doug. In your study, did you see any side effects with the use of cervical vagus nerve stimulation?
No, we really didn't. I mean, a theoretical side effect is hoarseness. We did run into some problems when we were trying to develop an active control, you know, the sham device that was delivering some electrical stimulation, and that we were getting some irritation in the skin and that. But you know, we've since moved to using devices that are not delivering that much electrical stimulation. But it's been very you know, well tolerated. I kind of jumped to another question I saw, that someone said that they had more anxiety when they were trying to use the true vagus system. You know, if anything, you know, what I see clinically is that some people have a greater ability to concentrate, or they're more focused. So, you know, maybe there's some sort of, maybe you could speculate there's some kind of activating effect that's occurring with vagal nerve stimulation that is causing someone to feel more activated. But, you know, I haven't seen you know, I haven't heard a lot of people complaining about describing that as anxiety per se.
Steve, go ahead.
Yeah, well, there's a similar effect we've seen with the Safe and Sound protocol, and that is if you come into the protocol with let's say, a very complex or deep trauma history, a severe adversity, It's not that the stimulator doesn't work or the vagal nerve, the body will calm, but it's the interoception, the feelings of now being calm are associated with abuse. And that is that second level. And the treatment model that we've been using is titration. Just let the body get used to it. And so what I think that person is saying is their body went to a state, and that state triggered an association, which made them feel very anxious. So in a sense, vagal nerve stimulation is calming. The body becomes like this. But that means accessibility for those who haven't had severe trauma histories. This is vulnerability to those with the trauma histories.
Yeah, I do remember I had one patient who said he was remembering more, like he was sort of shut down. And this was sort of causing him to kind of open up a little bit more. And it was bringing back a lot of memories. And some of them he'd rather just be shut down. That did happen. So we just, he stopped using it at that point. That was kind of that.
Yeah, that's very consistent with the model.
It's very interesting. Most people with either an implanted or external vagus nerve stimulator, and again, this is a scientific discussion, not a medical recommendation, actually have a significant improvement. But there are occasions where people don't do well. And I've wondered, maybe this is for you, Steve, or for you, Doug, slightly answered in slightly different ways. Is there a chance that we're stimulating the ventral vagus with, the dorsal vagus with an external vagus nerve stimulator by whatever means, auricular, SSP, or an external or implanted device?
Well, you're less likely to do it with the auricular, would be my guess. Let's say you're not doing it. You're getting the ventral vagus, but the physiological state of calmness is a trigger in itself to a person with a history. And so that history becomes deep. The bit with when they were doing the implantable vagal nerve stimulators, and if they had the current up too much, then they would affect the gut and genital activity. So people would have those complaints. The dorsal vagus, let me put a plug in for the dorsal vagus. It's extremely important in homeostatic function when it's not under a state of threat. And the critical thing, this is what polyvagal theory directs or sends a line towards, or a headlight. And that is that when you remove the ventral vagus, the rest of the autonomic nervous system is still in a hierarchical manner, but it's now in a state of defense. And its first reaction is fight or flight. But fight or flight is metabolically time limited. You can't keep it up. Then the body goes into this shutting down. It's a conservation response, and that's dorsal vagus. But when the dorsal vagus is not in that conservation of life threat, it reduces contractility, it improves, sends signals, or helps the digestive tract. It's very, let's say, it's very health giving. It's very much supportive of homeostasis.
Oh, that's good to hear.
So,
That's a
gentlemen,
good,
I'm
great
going
answer.
to, we are right at our time right now. I want to be respectful of our audience. And I want to thank you all for a very lively discussions, for some great presentations. Again, this has been brought to you by the Vagus Nerve Society and with two of our sponsors, the Polyvagal Institute and electroCore, the makers of the GammaCore device. So we thank you very much, and hopefully you'll join us on some of our webinars in the future. So thanks, everyone. Really appreciate it.
Thank you, guys.
Thanks.